Good morning. My name is Mila Maistat. I work with Medicine's Patent Pool as Senior Manager on Policy Strategy and Market Access. I would like to thank the organizers for inviting me to this important conference and apologize sincerely for not being able to come in person this time. Today I will be talking about access to viral hepatitis medicines and diagnostics in African region. Before diving into the subject of my presentation, I would like to remind you the following. Most essential medicines, including those for viral hepatitis, are patented. It means that prices remain high since only medicines from originator company or patent holder exist. Generic versions of patented medicines can only be available after patent expiry, minimum 20 years after a patent was filed. Here are just a few examples of what exactly it means for some key selected medicines for treating viral hepatitis B and C. Patent for tenofovir alafenamide expires in 2033, and for glecapril pibrentasvir in 2031, and some secondary patents in 2035. What does it mean exactly? It means that before the indicated years, generic versions of these medicines cannot be available. And I guess the question here is why exactly we need generic medicines? Existence of generic versions brings more competition, which results in lower prices, and consequently, more people in more countries can get access to them and get treated or cured. And here comes the next question. How can we make it happen? In other words, how can we get access to generic medicines? And here is where Medicine's Patent Pool, MPP, comes into play. MPP is a UN-backed public health organization established by UNITAID back in 2010 to facilitate development of generic medicines, their combinations, and new formulations, for example, pediatric formulations. We operate through voluntary public health-oriented licensing and technology transfer, and our work in HIV, viral hepatitis, and TB is fully funded by UNITAID. And let me briefly tell you how MPP operates, or how our model works. MPP is in the middle of this model, in the blue cycle, you can see it. The first thing we do is, together with WHO, community, civil society, governments, we identify which medicines are needed in countries and where licensing through Medicine's Patent Pool can make a difference. Then we approach patent holders, they are to the left of the cycle, and we negotiate license agreements with them on most public health-oriented terms and conditions, so that more countries and more people in those countries can get access to the needed medicines, combinations, and needed formulations. Then we sublicense, or we give licenses to generic manufacturers. They are to the right of the cycle. We usually give licenses to as many generic manufacturers as possible, or as many as necessary, to ensure generic competition. And as a result of this competition, the prices go down. The quality of generic products is usually ensured through WHO pre-qualification process or approval of other stringent regulatory authorities in countries. And that is how countries and people in those countries get access to the needed medicines, combinations, and formulations. These are the list of products licensed by MPP across different disease areas, including viral hepatitis. You can see that the list for HIV products is the longest one, since we started working in HIV back in 2010. And then, since MPP model worked really well in HIV, as the request of WHO, governments, and other stakeholders, we expanded our mandate to viral hepatitis and TB in 2016, and then gradually to COVID-19 and non-communicable diseases. We don't have to look in detail into each list now, however, we can always discuss it later in case of interest. I have included some figures here to give you a sense of some health and economic impact of MPP work. We have been working with 22 patent holders. In other words, we have licensing agreements with them. And we have sub-licenses with 56 generic manufacturers and product developers across different WHO regions. Since 2012 until end of 2023, more than 43 billion doses of treatments have been supplied to 148 low and middle income countries. Thanks to MPP license agreements, global health community saved almost $2 billion as of end of 2023, and this data will be updated soon. And now let us have a closer look at MPP work in viral hepatitis B and C. You can see here which products for treating viral hepatitis B and C are licensed by MPP. For example, we have licenses with Gilead for tenofovir, both for TDF and TAF, with BMS for the cladosphere, allowing also Daxof combination, and with EFI for glecaprevir pibrentasvir. Below each product name, you can see the year when the license was concluded and also a link to the license agreement in case you are interested to read it. And the squares contain a list of generic manufacturers manufacturing and supplying products to low and middle income countries. Let us have a closer look at access to HBV treatments, in particular entecavir and tenofovir. Both entecavir and tenofovir TDF are recommended by WHO. The good news here is that generics are available worldwide as patents for both tenofovir and entecavir expired. There are multiple quality assured generic manufacturers producing and supplying TDF to low and middle income countries, and now also for TAF. Prices for TDF through public procurement or through procurement agencies are less than $30 per patient per year for treating HBV. In cases there are no public procurement, unfortunately, many people pay more in private markets. And what about tenofovir alafenamide or TAF? MPP concluded license with Gilead for tenofovir back in 2014. The license allows access to generic TDF and TAF and their combinations. TAF was approved, as you know, back in 2016. And just like TDF, TAF 25 mg is also indicated for HIV and HBV, and now is a preferred option for HIV since July 2025. As you know, TAF proved to be safer for kidneys and bone density than TDF. Thanks to the MPP Gilead license, 117 countries can get access to generic tenofovir, TAF. Since 2018, 3.5 million packs of TAF 25 mg have been supplied to 20 countries, and procurements have been increasing steadily since 2024. In African region, Ghana, South Africa, and Tanzania procured TAF. Uganda and Zimbabwe registered it, and in Ethiopia, Kenya, Malawi, Nigeria, Zambia, TAF have been filed for registrations, which is kind of good news. I would like to highlight here again, all African region countries can procure generic TDF, and most countries in African region can procure generic TAF from MPP licensees. These graphs show procurement volumes of TAF in African region. You can see that Tanzania procured 4,000 packs, Ghana 2,500 packs, and South Africa just started procurements and procured less than 500 packs. And here are some key findings from our work in viral hepatitis. All African countries can procure generic medicines for treating viral hepatitis B, such as entecavir, TDF, TAF from multiple generic manufacturers. Prices for generic treatments continue to go down where there are national programs in place, countries such as Egypt, Rwanda, and others, where there are multiple manufacturers registered, where there are competitive procurement practices, including through international procurement agencies. And prices remain high where there are no national programs, where there is only one manufacturer or distributor in the country, where medicines are available in private market only. It can happen when there are no national programs in place and when suboptimal procurement practices are taking place. Let us move now to have a look at access to hepatitis C treatments. First, the cladosphere. The cladosphere, as you know, as combined with sofosbuvir, is one of the WHO recommended pangenotypic treatments. In 2015, MPP and BMS signed a license agreement for the cladosphere. The license agreement enables manufacturing and supply not only the cladosphere standalone, but also in a form of a fixed dose combination combining the cladosphere and sofosbuvir in a single tablet. The quality is ensured through approval of WHO prequalification or stringent regulatory authority. Originally, the license covered 112 countries and later was expanded to additional 39 countries, covered in total 152 countries. Currently, generic declatosphere should be available worldwide because of BMS patent withdrawal, and current benchmark price for declatosphere and sofosbuvir is $30 per treatment course. This map shows that over 5 million packs of the platasphere have been supplied globally, which is equivalent to 1.7 million treatment courses. 38 countries have been procuring it either directly or through Global Fund from MPP licensees. And these graphs demonstrate procurements of the platasphere 60 mg in African region from 2016 until June 2025. Cumulatively, over 250,000 packs have been procured for Cameroon, Congo, Mauritius, Nigeria, Rwanda, Tanzania, and Zimbabwe. This map shows that 590,000 packs of the platasphere-sofosbuvir combination have been supplied to 28 countries, which is equivalent to 196,000 treatment courses. In the African region, almost 250,000 packs of DAC-SOF combination have been procured by or for the countries mentioned along the horizontal axis. MPP has also a license agreement with AbbVie for another treatment option recommended by WHO, which is glycaprevir pibrentasvir, known as GP. GP is a highly effective pangenotypic regimen recommended by WHO and other international organizations as a first-line and second-line treatments. It has the shortest treatment duration, 8 weeks, including in cirrhotic patients. It is also safe to use in patients with kidney insufficiency. And the license between AbbVie and MPP was signed back in 2018. MPP generic manufacturers or generic partners have started developing GP, and generic GP is expected to enter markets in low and middle income countries in 2026, provided there is demand from countries, of course. I'm pleased to mention that all Afro countries should be able to procure generic GP as soon as it enters the market, which will happen if there is demand, of course. And here are some key findings in terms of access to viral hepatitis C treatments. Over the past several years, prices for hepatitis C medicines have come down significantly, more than 80% price reduction for the platasphere and 90% price reduction for DAC-SOF combination. The good news is that there are now multiple generic suppliers who can supply hepatitis C treatments to all WHO regions, including Afro region. However, many countries are still facing some challenges. Talking about remaining challenges, let us have a closer look at them. In-country registrations. Low prices apply where there is competition. Many countries have no or only one locally registered product. How you can address it? Please flag it out to MPP. We can encourage manufacturers to come to countries and register products if there is demand, of course, for these products. Lack of national programs. Unfortunately, in some countries, there are still no national programs. However, we believe that securing more affordable medicines can encourage countries to develop national programs and facilitate diagnosis to generate demand for treatments. High prices in private markets. Unfortunately, in private markets, people pay out of pocket and medicines remain unaffordable. What can be done? Explore procurements through international agencies if appropriate. A few words regarding possibilities to procure through international agencies. You and other stakeholders in countries can have a look into possibilities of procurement through, for example, Global Fund, UNDP, IDA Foundation, UNICEF, and other international organizations and mechanisms. They have negotiated long-term agreements with suppliers, including MPP licensees. They can procure upon request from governments who can benefit from prices they have negotiated, and in some cases they can also procure upon request from individual hospital facilities. And finally, I would like to share with you some lessons learned from our work. First, that achieving elimination goals is not possible without ensuring access to quality-assured generic medicines for low and middle-income countries. Otherwise, treatment would be unaffordable. However, affordable medicines are not enough to ensure that people in need get them. In many countries, unfortunately, uptake of hepatitis B and C medicines has been very slow and low for following reasons. For example, HBV and HCV are not prioritized, there are no national programs in place, or there is lack of funding, no screening, high prices, etc. Low and uncertain demand slows or even stop development by generic manufacturers. Availability of affordable quality-assured medicines can help governments to plan, launch, and implement treatment programs in countries. And I would like to highlight again that more affordable, quality-assured generic treatments for HBV and HCV are available for all countries in the African region. And a few words about diagnostics. First, I would like to mention that MPP was created to expand access to medicines. We have not worked yet on diagnostics. However, I must admit that we have been approached by many stakeholders requesting that we expand our mandate to diagnostics. So far, I can share some general information on current situation with access to viral hepatitis diagnostics, which we have collected based on our work with partners. The market for hepatitis C and B rapid diagnostics have been growing substantially since 2021. Most private markets in low and middle income countries are often driven by tests not pre-qualified by WHO, which raises concerns about quality control. At the same time, countries in Africa have more support from funders like Global Fund, for example, through which quality-assured diagnostics can and is procured. Access to point-of-care molecular diagnostics for hepatitis C confirmatory RNA and HBV monitoring test DNA is a major challenge. Prices are often higher than treatment. For example, prices could be within the range of $15 and $100. And here are some current and potentially future solutions in terms of diagnostics for viral hepatitis B and C. First, the new WHO guidelines for HBV approved in April 2024 allow treat-all approach, as you know, which means that all people screened positive for hepatitis B surface antigen can be treated if HBV DNA assay is not available and liver enzymes are persistently elevated. In terms of innovations, HBV co-antigen diagnostics is being tested as market for treatment eligibility. In other words, it has potential for replacing expensive molecular diagnostics. In relation to hepatitis C elimination from the point of view of public health, WHO and other international guidelines, such as EASL, for example, or SLD, remove post-treatment viral clearance confirmation assay, given the high cure rate of DAAs. And this assay, as you know, is done 12 weeks after end of treatment. It means further cost reduction of diagnostics. And finally, for rapid diagnostics, you can explore procurements through Global Fund and other pool procurement mechanisms. For example, price for HBV rapid diagnostics test is under half of US dollar from Global Fund procurement and slightly more than $1 from UNOPS procurements. I think this is all from my side, and I would like to thank you for your attention. Please feel free to reach out to me in case you have questions or need more information in relation to access to hepatitis B and C medicines and diagnostics in your country or region. I'm very much looking forward to seeing you in person next time. Thank you.